Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from GSK.
This program is presented by Medscape Education Global.
Hello, I'm Dexter Wiseman, a consultant in respiratory medicine at Chelsea and Westminster Hospital and an honorary senior lecturer at Imperial College London in the UK. I've conducted research looking at the burden of RSV in adults and focusing on adults with comorbidities. A warm welcome to this program titled Unveiling the Invisible, the Acute and Chronic Burden of RSV Disease. I'm very pleased and honoured that we have Dr. Maja Sikes joining us virtually today. Dr. Sikes is the head of the Heart Failure and Mechanical Circulatory Support Unit at the University of Zagreb School in Croatia. Welcome, Maja.
Thank you very much for the introduction, Dexter.
It's also my great pleasure to be joined by Jane Van, who is here with us to provide a patient's perspective on RSV. It's so important to hear from the people directly affected by the virus, and we're very grateful she's given up her time for this discussion. A warm welcome, Jane. Thank you for being here and for your willingness to share your experience. In this program, we'll start by providing an overview of the burden and clinical features of RSV in adults, before hearing from Jane about her experience as a patient affected by RSV. We'll then talk about the risk factors for severe RSV disease, its long-term complications, and also review the latest clinical data on RSV vaccines, which are an important factor for preventing negative outcomes for RSV infection. We will then hear from Maja about her perspective as a cardiologist taking care of patients who may be at higher risk for severe outcomes from RSV, and discuss how we can all effectively implement RSV vaccines in clinical practice. So let's get started. I've taken this image from a review called Protective and Harmful Immunity to RSV Infection. I think it very concisely summarises the impact that RSV has throughout life. For infants, it's the primary cause of hospitalisation and is responsible for many primary care encounters every season. From young childhood until older adulthood, RSV doesn't appear to cause as much of a burden amongst healthy individuals, although it has been found to trigger asthma and COPD exacerbations. On the right are the elderly cohort of patients, where RSV is again a significant cause of hospitalisations and confers a large burden of disease, especially amongst those with underlying comorbidities. The immune protection from RSV wanes, and individuals are again susceptible to becoming unwell through processes known as inflammaging and immune senescence. Much like flu, RSV is a seasonal virus, although it usually slightly precedes the flu season, and pre-COVID its timings have been quite predictable. In Europe and USA, the season is mainly October to February and does alter very slightly country by country as per the graph. The graphic at the top is a nice visualization of RSV seasonality over the year globally, and this is comparing and contrasting the RSV season to flu. Seasonality for older adults and infants is very similar, with some studies indicating that there is a slight delay in the older adult peak by a couple of weeks, and this is possibly due to older family members contracting the virus from infants in the household. RSV seasonality was altered during the COVID pandemic, however it's now largely returned to pre-pandemic patterns. Maja, did you want to talk to us about how people can look at the respiratory update and historical detection data of RSV in Europe?
Indeed, absolutely, Dexter. I think it's interesting to point out to our viewers that we can track these data virtually live. For instance, the European Centre for Disease Control publishes weekly respiratory updates, which are also overlain on historic detection data. Here you can see the data that we have, for instance, for the first week of this year, of 2025, where you can see that from the symptomatic patients that were tested for respiratory viruses, at that point, first week of January, 10% of them had positive tests for RSV. On the lower part of the graph, you can see depicted the real-time results on top of the historic data, where we can track the predicted further trace of these epidemics, you can see that the RSV numbers are currently peaking as we would expect that to be, and probably will have a downward trend from there on.
Thank you, Bea. So RSV replicates in the respiratory tract, which results in primarily respiratory symptoms. The virus enters the airway through the nose or mouth. It infects mainly the ciliated cells and then moves down into the lower airway. Viral replication is also more effective in the lower airways, and this has been demonstrated in both infant and animal studies. This lower airway replication propensity could explain why older adults with chronic lung conditions such as COPD appear to be so affected by RSV. This table shows viral symptoms from community-dwelling adults. It was from a study that included over 36,000 adults from Europe, Asia, and America. Looking across the table, it's clear that the symptoms of RSV, influenza, metapneumovirus, rhinovirus, and coronavirus are all very similar. And this detailed symptom list found cough, fatigue, nasal congestion, and headache to be the most common outpatient symptoms for RSV. This table looks at the burden of disease and is taken from a systematic review and meta-analysis by Prof. Van Tam and colleagues. They found an estimated 7.8% of respiratory infections were caused by RSV when looking at studies conducted during the winter season. The proportion of RSV infections was higher in medically attended populations compared to community-based populations. They also estimated that 27% of cases developed pneumonia, 24% required hospitalization, and 5% ITU. Fatality was at just over 8%. Amongst the high-risk groups, this increased to 33% needing hospitalization and 27% ITU. The UK hospitalisation data has been investigated for adults over the age of 64 admitted to English hospitals between 2010 and 2017. They found that for adults over the age of 64, there were 71 admissions per 100,000 patients, and for adults 75 and over, there were 250 admissions per 100,000 patients. Burden for RSV was greater than for flu A or for parainfluenza. A separate paper found that in the UK annually, for adults over the age of 18, there were estimated to be 450,000 GP appointments, nearly 18,000 hospitalisations, and over 8,000 deaths caused by RSV. Of those, 36% of GP appointments, 79% of hospitalisations, and 93% of deaths were in the 65 and over year age group. RSV is known to cause outbreaks in hospitals, and there are a number of case studies examining this. This case study was in a French hospital for adults where the mean age was 89 years old. Despite RSV being identified and infection control measures in place, RSV ran rampant through this hospital and unfortunately caused multiple morbidity and 2 fatalities. The economic burden of RSV has been investigated recently in a paper from August 2024. They found there was an estimated 4 million RSV cases amongst adults over the age of 60 in the United States, with an annual estimated economic burden of $6.6 billion, and that included both direct and indirect costs. The 4% of hospitalised cases accounted for 94% of all those direct costs. As has been indicated in some of the data presented so far, advancing age is a major determining factor in RSV outcomes. A surveillance study found that 0.8 cases per 10,000 persons per year of RSV were in the 50 to 64 year age group, 2.5 cases per 10,000 per year in the 65 to 79 year age group, and 5 cases per 10,000 per year in the over 80 age group. The graph shows the survival estimate after admission with RSV from a paper by Tsung and colleagues. And in this study, which was for hospitalised adults over the age of 60 who had a positive test for RSV, 664 adults were hospitalised, half had radiologically confirmed pneumonia, and 21% required ventilatory support. In the 60 to 74 year age group, survival was 84% at 1 year, dropping to 68% in the 75 and over year age group. Also from the same study, they looked at long-term outcomes of RSV compared to flu. The study included 645 RSV cases and 1,800 flu cases. RSV infection was associated with greater odds of a length of stay for more than 7 days, pneumonia, intensive care unit admission, exacerbations of COPD, and also a greater mortality within 1 year of admission. As the graph shows, at 1 year, the survival rate after an influenza admission stands at 81.2%, whereas it is 74.2% for RSV. Jane, thank you for joining us today.
Pleasure, Dexter.
Could you tell us about the onset of your symptoms when you had RSV infection and what caused you to seek medical attention?
Yep. It was a Friday evening. I started to feel really unwell. I'm used to having severe asthma, but I also recognised it was something more than just my asthma, because it wasn't just my chest. I felt so unwell in myself. So sort of went to bed early, just rested, couldn't eat. Saturday, I felt just as ill, but not particularly worse. But then Saturday evening, I couldn't sleep all night. I stayed up all night. Sunday morning, I was dreadfully unwell. And I normally try not to go to A&E with asthma. And so my family were very shocked when I said, I need to go to A&E. So Sunday morning, about 8, 9 o'clock in the morning, we went straight off. And it was just so unusual for me. I'd normally try and brush my hair, teeth, look normal, but I couldn't. I even went in my slippers, and I felt that unwell. And I got there and saw the triage nurse, and I was immediately taken through to A&E and put on oxygen and took blood tests, all the ECG things. And then 2 doctors bounced back in and said, "Oh, poor you, you've got RSV," which I'd never heard of, despite following asthma and lung disease over 50 years of having asthma. And I had to ask what that was, and they said, "Oh, it's a nasty virus. There's no treatment for it. You just have to sort of endure it." And then he said, "But what we're really worried about is it sent your heart rate racing up to over 160. That was my first initial thing on admission.
Yeah. And can you describe to us your hospital stay and what happened to you during your hospital stay with
Yes, I was admitted onto the ward, and I had oxygen. And funnily enough, for the first time, because obviously when I've been admitted over the years with asthma, I've had oxygen before, but I was allowed out of bed so I could sort of go to the loo myself very slowly. But it was the first time I'd really experienced having oxygen. I didn't take the oxygen with me, obviously I left that. But I was desperate to get back to bed to put the nasal cannula back. I was very, very breathless. I noticed that. I had nasal congestion, and the other very weird symptom, which don't know how common it is, and I noticed it when I was admitted and I was still on A&E and the doctors were talking to me. At one point, I couldn't hear the doctors. My husband was with me, and I said, "I can't hear what the doctors are saying." And my hearing went completely. And my husband sort of talked to them about it, and they just said, "Oh, it's probably temporary, it will come back." And I felt so ill, I wasn't even that bothered about that at the moment. It's more bothered about trying to breathe and cope with this feeling of being very, very unwell. And it lasted for about 4 or 5 days, to the point I told my husband not to let visitors come because I simply couldn't hear them. It was, too trying.
And remind me, how long were you in hospital for in that admission?
Exactly 2 weeks. Mm-hmm. And they did say initially, when they come round and they try to reassure you, "You've got RSV, you'll probably be here with us for about a week." But after the first week, I was aware that I was going to be in longer. It wasn't a surprise because I was just so unwell. My chest was very tight, very wheezy, and I couldn't cough up mucus and phlegm, and I was put on carbamazepine to help with that. And the physio came round and things like that. So it was very, very, very hard to clear my chest, much more so than just when I've had an asthma exacerbation.
And after discharge from hospital, how were those initial few weeks being back home?
Well, I certainly felt a lot more tired. Things like walking upstairs made my legs tremble, things like that. So I felt very weakened by the virus. My husband had a bad cold when I went home, so I went to stay with my daughter because we didn't need any more complications. And I thought, okay, day or two of resting. I'm on steroids, which tends to perk you up. But literally for about 5 days, I could do no more than just rest on the sofa, dozing, waking up, that kind of thing. My hearing returned. That was good. But yes, it was a slow thing back. And after about a month. I think I was in hospital on my birthday, so I came out on, I think it was November the 2nd, and on December the 8th, my daughter suggested I flew out to Istanbul just for a little city break to get over it and do something nice. And I was there from the Friday to the Sunday late afternoon. I started to feel very unwell, and we were coming home on the Monday, and I suddenly realised I always take a pulse meter with me, and my blood gases are normally 97, 98, occasionally 99, and it had gone down to 92, which shocked me. And I realised I probably was going to be a liability on the plane coming home. So I knew I needed medical help. So the concierge sent out some paramedics, and they did all the normal tests, and I was admitted to hospital in Istanbul. And I was there for a week, and I had pneumonia. So it was only a month after the RSV, so I assume I hadn't fully recovered from that and was unwell.
Maya, do you have some questions for Jane?
Yes, thank you very much, Dexter. I in fact do, and thank you very much, Jane, for sharing your experience with us. It's so important for us always to learn from our patients. I was wondering, how do chronic complications impact your day-to-day life?
Quite a lot, although when you ask me, it's sometimes quite difficult to identify them because I'm so used to doing them. I do work, and my boss, since I came out of hospital in Istanbul, I couldn't return. I came back on the 16th, 18th of December, and I didn't return to work till about something like January the 20th, something around that date. And he very kindly gets me a taxi to and from work. He says, I'm picking up all these viruses on the tubes and buses and mixing with loads of people. So he really values what I do, so he does that. And I'm very aware that sometimes with just having asthma alone, that things like tube stations, I live in Putney in southwest London, and none of the stations have lifts or easy ways of getting up the stairs. And if I'm very wheezy, I know there's about 54 stairs at Putney Bridge Station and about 40 at East Putney. So you have to factor all that sort of thing in your day-to-day life, and what tube stations you use and what stairs there are and things like that. I never leave home without my inhalers and medications, and I always take a little pack of my prednisolone, and if I've got a rescue pack of antibiotics, I just carry them with me so that I know if I get anything, I can start treatment immediately, hoping to minimise how long I'm going to be unwell. It also impacts my social life quite a lot. I'm a big cinema goer, and I go with a group of friends, and obviously quite often I have to back out of that because you can't be coughing in a cinema and irritating lots of people, and again in restaurants. And particularly since COVID, if people hear you cough, they automatically assume you're infectious. And quite often I find myself, even if I'm going in a taxi in the morning and I'm a bit breathless or something like that, I always say, so sorry about my cough, but don't worry, I'm not infectious. I just suffer from asthma. And a couple of times I was on a bus actually, going to the Chelsea in Westminster to see my asthma nurse. And there was a lady sat next to me, and she said, "Oh, what are you suffering from?" And I said, "Oh, it's only asthma, I'm not infectious." And she said, "Oh, good, because I'm going to the Chelsea in Westminster. I'm a cancer patient." So I think certainly since COVID, people are very worried about picking things up. So it seems very even more antisocial than usual since COVID. So yes, a lot of things you sort of have to think about, and whether if you're going on a trip with somebody, you're going to slow them up, you're going to Bath, oh, that's hilly, should I go? But when you've had a chronic disease for a long time, I think it just blends in with your life. And in the end, it becomes seamless. It's just what you do, if that makes sense.
Absolutely, absolutely. And have there been any changes in your asthma therapy following your RSV infection?
Yes. My steroid inhaler was doubled. And then, of course, I was ill in Istanbul, and we all agree I wasn't fully recovered from the RSV. And the Chelsea and Westminster put me forward for biologic treatment, which I was referred to the Brompton, and I'm on that now from May last year, and that has definitely reduced my asthma symptoms, in that if I get a nasty virus or a cold, instead of sitting up all night with a pillow on my kitchen unit, sort of not being, leaning forward because I can't lean back or go to sleep, worrying if I ought to go to A&E, it more or less becomes manageable at the level of a normal person without asthma, if I'm lucky enough. So I just feel dreadful, achy, cough, but I can contain it just with my steroid inhalers, possibly a 5-day prednisolone course of 40 milligrams, something like that. But it doesn't stop me being out and about to a degree. I can still function.
Glad to hear that point. And I'm curious, Jane, were you aware that having asthma puts you at a particular risk for becoming unwell with RSV?
No, and mainly because I'd never heard of the virus, despite being on a forum, Health Unlocked, for all lung patients, everything from COPD, asthma, fibrosis, transplants, everything. I'd never once heard a mention of RSV. The first I heard was when the 2 doctors came in with the results of my blood test saying, "Oh, you've got RSV," and we went, "What's that?" I'd never heard of it. So that was an eye-opener, never heard of it at all. So I wouldn't have known I was at risk of it because I simply didn't know it existed.
Understandable, absolutely. So, in fact, with the current knowledge and experience that you have, if it was offered to you, would you have chosen to be vaccinated against RSV?
Oh, yes, absolutely. And because obviously for my age group, I would need to pay, and I am going to do that. I think it's really worthwhile. I wouldn't like to get that again, or certainly not that severely.
Thank you very much, Jane, for sharing your experience with us. It's really extremely valuable for us to learn from our patients. Thank you for that.
Thank you, Jane. So, Maya, when Jane was admitted at Chelsea and Westminster, other than the supportive care that we gave her, oxygen, fluids and some antibiotics because we thought she maybe developed a secondary bacterial infection, could we have managed her any differently?
This is one of the challenges that we do face with RSV, where with patients that develop the disease as Jane did, we feel fairly unable to help them to further depths because other than supportive care, there aren't targeted therapies that we can use specifically for this patient population.
And when it comes to Jane or patients that are at risk for severe outcomes for RSV, including heart failure, do you follow them up any differently compared to non-RSV related admissions once they've been discharged from hospital?
Yes, absolutely. I would just also briefly start by saying that from the cardiology perspective, we also do involve shared care with our pulmonologists, infectious diseases specialists, when our patients with heart failure or other cardiovascular diseases, of course, acquire the virus and respiratory illness. In terms of follow-up of these patients, it is also a shared care-based follow-up. Speaking from the cardiology perspective, we definitely do want to monitor their heart failure status. The majority of our patients would have that syndrome, of course. Would want to monitor their medications, titrate their diuretics as needed, sometimes up titrate, sometimes even down titrate depending on the fluid balance during and after the infection itself. So we would definitely keep a closer eye on our patients following the infection, yes.
And with budgets limited and patients often attending just once, maybe a season for a vaccine, how do you feel that the RSV vaccine sits amongst COVID and flu vaccines?
Thank you for the question, Dexter. And you've really shown us very robust data that emphasize the long-term outcomes with RSV disease compared to, for instance, influenza. So definitely we do still appreciate and continue to appreciate the relevance of seasonal vaccines for influenza and COVID-19. But I think we should definitely promote the position of the RSV vaccine, especially in the target populations, and the ones that we are mostly discussing today are elderly people with comorbidities. In cardiology, the poly pill was very popular and mostly, well, even in a broader context of prevention. If thinking in terms of uptake of medications, adherence, etc., that we know is so much better with combined medications in one tablet, thinking about combined vaccinations that would provide a single shot, amalgamating these relevant seasonal vaccines, I think would definitely bring benefit and better uptake for our community.
Thank you, Maya. So could you please expand and tell us what we know about who is at risk for severe RSV disease and some of the chronic complications associated with RSV disease and RSV infection?
Absolutely. So some of the main points that we want to emphasize in terms of those at risk are certainly patients with increased age. Comorbidities that both you and I manage in our patients, cardiovascular disease, lung disease, but also others, and I will come to the data, are also aggravating factors and risk factors for our patients. Poor nutrition, low socioeconomic status, smoke exposure, all play an important role as risk factors for severe RSV infection. But to go a little bit more into detail, we know clearly that the disease burden is higher in older compared to younger adults. Other risk factors certainly include comorbidities such as COPD, asthma, heart failure. Also, we shouldn't forget those with an immunocompromised status. There is a fourfold increase in the risk of RSV-associated respiratory infection among patients with any comorbidity compared to those without, particularly in patients that are age 65 or older, and mainly those in institutions, and adults of any age with comorbidities that we have been mentioning. In some words, I think we can summarize this by saying that, unfortunately, RSV affects the most vulnerable. Another point that I would like to emphasize is the bidirectional association between cardiovascular disease and RSV. There are some facts that we know, and what I would really like to emphasize is that in patients with underlying cardiovascular disease, this has been associated with an increase in hospitalization, which is 45 to 63% more frequent than in adults not having cardiovascular disease, and these are hospitalizations, of course, of adults with confirmed RSV. In the other direction, it also holds true that hospitalization for RSV can be complicated by cardiovascular events in around 14 to 22% of adults. These cardiovascular events that can complicate an RSV hospitalization would typically be worsening heart failure, acute coronary syndromes, or arrhythmias. And then it's interesting to think about how a virus would affect these downstream occurrences that we can see in terms of cardiovascular disease. First of all, clearly, Dexter, you've told us how the virus affects the respiratory tract, and even all of these indirect effects, such as respiratory infection, increased fever, which leads to an increased metabolic demand, hypoxia, perhaps hypotension, hopefully not shock, but it can also occur in different viremias, decrease the oxygen supply demand, and create an imbalance in these two factors to the heart itself, creating something that we term type 2 myocardial infarction. These are indirect effects, but we also need to appreciate the direct atherogenic effects of viral infections, which increases inflammatory cytokines, monocytes and neutrophils, leads to inflammation, plaque destabilization, and the true type 1 MI that we see in atherosclerotic heart disease, but can be facilitated by, for instance, RSV infection. And the last point that we should also not forget about are direct myocardial effects of viruses, which can cause viral myocarditis, of course, leading to heart failure, similarly as myocardial infarction, also leading to arrhythmias that we obviously want to avoid in our patients. So this also brings us to the further question, how can we identify patients who would benefit, in fact, from RSV vaccination? And here data from a study involving 756 patients that were hospitalized with an RSV diagnosis, where looking at the prevalent comorbidities, these were definitely hypertension in more than 76% of the patients, COPD in more than half of them, and high cholesterol in a similar proportion. Looking into predictors of hospitalization of patients hospitalized with for high-risk RSV, we can see that definitely these predictors narrow down to increasing age, as we have mentioned several times, comorbidities, primarily COPD, congestive heart failure, chronic kidney disease as well needs to be emphasized here, as well as hematological malignancies. So these are some comorbidities that the patients would already carry and would be predictors of hospitalization. So we need to think of those patients as candidates for vaccination. Further on, looking at the same cohort of patients during the 180 days post-RSV diagnosis, the most predominant complications were respiratory tract infections, pneumonia, dyspnea, and arrhythmias. So again, something that we want to prevent by vaccinating our target population. Another cohort that is interesting to me as a cardiologist are patients that were hospitalized in the United States between 2015 and 17 for RSV-associated disease. What was shown in this cohort that adults with congestive heart failure had 8 times the rate of RSV-associated hospitalization compared to those without congestive heart failure. And you can see that this discrepancy and, of course, the incidence of hospitalization was even higher in those age 65 or over. So how are the vaccines available to us? What do the guidelines say in different regions? And I do want to stress out that the guidelines and recommendations would vary, for instance, by region within Europe. First of all, in 2023, the European Union approved the first RSV vaccine that is suitable for protecting infants up to 6 months of age, as well as 2 vaccines for older adults. You can see, for instance, in the UK guidelines and recommendations that there is clear guidance on RSV vaccination of pregnant women for infant protection, those typically around 28 weeks of pregnancy. But turning to older adults, for instance, in the UK, there is also clear guidance that older adults aged 75 or higher do have a recommendation to use the RSV vaccination. You can also see here the CDC recommendations that follow the same age of 75, but also lower this threshold to those age 60 and over with certain comorbidities that we were talking about that would increase their risk. Now, how about specific patient populations? I find it very interesting that the oncology community clearly recommends immunization, the RSV vaccine, for adults with cancer aged 60 years and older, so an even lower threshold, once in order to prevent the virus-associated disease in adults with cancer. In our field of cardiovascular disease, here you can see an amalgamation of different recommendations for targeted diseases within the cardiovascular community. And while there are clear recommendations for instance, vaccination against influenza, COVID, etc., for the majority of the patient groups, we do need more guidance and more data in the field of cardiovascular disease in terms of RSV vaccination. And Dexter, handing it back to you, speaking of vaccines, can you please tell us a little bit more about this field? What do we have available to prevent RSV infection? And of course, the potentially serious outcomes that we have been talking about.
Thank you, Maya. That was really interesting. So, well, as you say, there are now 3 older adult vaccines on the market. What I find quite interesting is why those vaccines are suddenly available, why after many years of research we've come up with older adult vaccines, and in different territories they're available for use. So I think one of the main reasons for that is the recognition of the burden in older adults. This is something which has only really been reviewed since Professor Fols's work in 2005, where she had 3 cohorts of older adults, some with comorbidities, some without. She was diagnosing RSV using viral culture and PCR and found that infection developed annually in about 3 to 7% of healthy elderly patients and 4 to 10% of patients that in the high-risk groups. And this is the first time that had really been demonstrated in a robust study. RSV was found to be responsible for about 12% of COPD admissions and 7% of asthma admissions in those over the age of 64. One of the other reasons why this knowledge is improving is the improvements in diagnostics we've been seeing since the 90s with the greater adoption of PCR, where previously viral culture was the standard method of diagnostics, which itself is fraught with difficulties. Our knowledge of RSV diagnostics in adults has continued to develop, and we now know that adding multiple diagnostic methods to nasopharyngeal swabs can increase the diagnostic yield further. This graph is from a prospective cohort study of patients aged over 40 hospitalised for acute respiratory illness. Nasopharyngeal swabs, saliva and sputum specimens were collected, and serology specimens were obtained at acute and convalescent time points. Adding all of the other specimens to a nasopharyngeal swab corresponded to a 2.6 greater diagnostic yield for RSV compared to just nasopharyngeal swab alone. And lastly, and more specific for the vaccine development, was the stabilisation of the RSV F protein, which was accomplished in 2010. Prior to this, we knew the F protein had two forms, the pre-F and the post-F, but the different epitopes or areas of vaccine attachment couldn't be studied in detail. Since this advancement, vaccine manufacturers are now able to create vaccines specific for this protein, which is known to be highly immunogenic. So it's therefore been a very exciting time in the last few years with regards to RSV prevention. And we've gone from having no available RSV vaccines on the market to having 3 main market-approved vaccines depending on the territory. As you can see here, however, there are also a number of other vaccines for older adults in various stages of development, including some which are combination vaccines that target more viruses than just RSV alone. There are 3 main vaccine candidates on the market, as I previously mentioned, and they all target the F protein, which is known to be highly immunogenic. The first one I'll discuss is the RSV pre-F vaccine. It's a recombinant RSV pre-fusion vaccine, and it's bivalent against RSV-A and RSV-B. In a phase 2 challenge study in adults, there was reported to be 100% observed efficacy against mild to moderate illness. The phase 3 studies are yielding very interesting data. According to the trial findings, the vaccine showed a 77.8% efficacy against RSV-associated lower respiratory tract disease after the second season, which was a slight decrease from the 88.9% efficacy showed after the first season, and this demonstrates durable protection. Less severe lower respiratory tract disease, which they define by 2 or more symptoms, dropped slightly from 65.1% after season 1 to 55.7% after the end of season 2. Safety profile after 1 month is acceptable, with incidents similar in the vaccine and placebo groups. And the vaccine's also been evaluated in a study looking at adults aged 18 to 60 with comorbidities, and they were randomised to the same vaccine or placebo. They found the safety profile was very similar to the older adult group, and this patient group demonstrated a neutralising response the same as the older adult cohort, which has shown efficacy. We're now getting some real-world evidence of the RSV pre-F vaccine, and that shows effectiveness of 91% against RSV-related lower respiratory tract disease requiring hospitalisation or ED visit amongst adults over 60 in the first 5 months after vaccination. The second vaccine candidate I'll discuss is the recombinant RSV pre-fusion F subunit antigen with AS01 adjuvant, and this adjuvant promotes a T-cell mediated immune response. It's monovalent against RSV-A and targets an epitope which is well preserved against the A and B subtypes of RSV. It's been reported to elicit a 10-fold increase in RSV antibodies versus baseline. Season 1 shows an efficacy of 94.1% against severe RSV-related lower respiratory tract infection and 71.7% against RSV-related acute respiratory illness. Efficacy does drop over the seasons, but we can see here that after a single dose, cumulative efficacy over 3 full RSV seasons was 62.9% against RSV lower respiratory tract disease and 67.4% against severe RSV lower respiratory tract disease. In the third season, the efficacy was 48% against RSV lower respiratory tract disease. Regarding safety, there was a little more pain and fatigue in the vaccine group compared to placebo in the initial month, but these were transient and resolved. Serious adverse events were similar in the vaccine and placebo groups. Additionally, vaccine efficacy has been inferred in adults aged 50 to 59 years at increased risk for RSV disease based on the immune responses to the vaccine observed in a recently published trial. The third vaccine is the encapsulated mRNA-based vaccine encoding the RSV F glycoprotein stabilised in the pre-F conformation, mRNA 1345, and this is monovalent for RSV-A. Antibodies to the epitope chosen on the F protein cross-react between RSV-A and B as they target a well-preserved region. Looking at the efficacy and safety profile, during initial follow-up the RSV vaccine showed efficacy of 83.7% against 2 or more symptoms and 82.4% against 3 or more symptoms when compared to placebo. The efficacy at 18 months had been shown to be 50.3% for 2 or more symptoms and 49.9% against 3 or more symptoms. Initial safety profile shows adverse events occurring more often with the vaccine when compared to placebo, but serious adverse events did not differ between the placebo and treatment groups. Now back to you, Maya. Can you share some tips about how we can increase awareness against RSV or about RSV and better communicate with at-risk patients about the importance of vaccination?
Absolutely, as Dexter, there are definitely several good pathways that have been charted out in the literature, and I would like to start by sharing a study that was performed in Italy, querying health professionals' attitudes regarding the need of more information about RSV vaccination and its delivery to older patients. As you can see from the results of this study, a vast majority of the queer health professionals somewhat agreed or strongly agreed with the fact that they need further information about vaccination in older adults and chronic patients, and also that they need further information about the new RSV vaccine. Most of them really clearly agreed with these 2 points, certainly more than those that think that patients are being offered, for instance, too many vaccines, or that patients would have concerns about the safety of the new RSV vaccine. So this really goes to show that programs as the one that we are delivering right now are important to our medical community and even wider to the whole health professional community in order to understand better, have better knowledge, and thereby be more prepared to deliver such therapies and vaccines. Another concept that has drawn a lot of attention in also the cardiology world was the nudge trial concept, which is specifically a series of clinical trials and their sub-analyses coming from Denmark, from the group of Professor Thor Bering Sørensen, where they really used the capacity of the Danish healthcare system to the maximum in terms of using the nationwide health registries and identification of the target population or the population of interest, which was also the source of all baseline data and outcome data for these studies. They then use nudges. Nudges are seen as interventions that are designed to influence decisions without restricting the choice of patients, of caregivers, etc., and that may be utilized to improve randomized encouragement trials, as well as other efforts to optimize real-world implementation of guideline-recommended interventions. So what they did specifically here is create a series of letters that were designed with behavioral science by which they wanted to nudge the Danish population. These letters were sent out through the government electronic letter system. And specifically in this trial, it included all Danish citizens aged 18 to 64 years who met criteria for free of charge, in this case, influenza vaccination in light of pre-existing chronic disease. And what was shown here, and these are only some of the results, that those that were randomized to receive a letter emphasizing the cardiovascular gain of influenza vaccination, or those that received a letter, that were randomized to receive the letter of respiratory gain in terms of influenza vaccine, had a significantly higher uptake over time and also sooner, as you can see, of the influenza vaccination as compared to those that were randomized to usual care. So I think this is a very interesting platform that can, of course, not only be utilized for influenza vaccinations, as the researchers did in the wider Nudge flu trial context, but also other vaccinations, as well as real-world implementation of guideline-recommended interventions. In terms of specific patient populations receiving the RSV vaccine, another study that I found interesting to our target population, patients of high-risk heart failure, was an open-label prospective study of 105 patients with high-risk heart failure that received with this study a concurrent influenza and RSV vaccination. Adverse events were collected in the first week post-vaccination, and overall, these vaccinations were well tolerated. The most common reaction, as expected, was injection site pain. General symptoms occurred in 33% of the patients. Most frequently, these were fatigue, myalgias, and headaches. Only a few experienced temperature elevation or flu-like symptoms, which were managed with antipyretics in this patient population. And importantly, there were no exacerbations of heart failure, hospitalizations, or death within this week post-vaccination when the patients were followed up, which highlights the safety of simultaneous, as also partly we've discussed earlier, influenza and RSV vaccination in a high-risk heart failure population with a low incidence of mild adverse events.
Thank you, Maya. So, looking through what we've learnt today, I'd say the take-home points for the talk: RSV can affect all ages, but the largest burden of illness is in infants and older adults. It's a seasonal virus. Its symptoms are indistinguishable from other respiratory viruses, indicating the need for testing. Burden of RSV in older adults in industrialized countries is comparable to flu. Advancing age and comorbidities are associated with worse outcomes, and there is a strong bidirectional association between RSV and cardiovascular disease. There are now 3 vaccines available for older adults on the market, depending on the territory, with more in development. And with that, we have to bring this program to a close. Thank you, Maya and Jane. It's been a real pleasure to discuss this important topic with you both. And thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.
I think this image very concisely summarises the impact RSV has throughout life. For infants, it's the primary cause of hospitalisation and is responsible for many primary care encounters every season. The elderly cohort of patients, where RSV is again a significant cause of hospitalisation and burden, especially amongst those with comorbidities. The immune protection from RSV wanes, and individuals are again susceptible to becoming unwell through processes known as inflammaging and immune senescence. Much like flu, RSV is a seasonal virus, although it usually slightly precedes the flu season. In Europe and USA, the season is mainly October to February, and it does alter slightly country by country as per the graph on the bottom of the slide. RSV replicates in the respiratory tract, which results in primarily respiratory symptoms. It enters the airway through the nose or mouth and infects mainly the ciliated cells. The replication is more effective in the lower airways, which could explain why older adults with chronic lung conditions such as COPD appear to be so affected by RSV. This table shows symptoms of RSV as compared to other viruses, and all of these symptoms are very similar. The detailed list found cough, fatigue, nasal congestion, and headache to be the most common outpatient symptoms for RSV, but the take-home point is that you can't distinguish RSV from other viruses based on symptoms alone. Looking at the burden of RSV from a meta-analysis of over 23 studies, they estimated 7.8% of respiratory infections were caused by RSV, 27% of cases developed pneumonia, 24% required hospitalization, and 5% ITU. Fatality was at just over 8%. Looking specifically at the high-risk group, this increased to 33% needing hospitalizations and 27% needing ITU. The UK hospitalisation burden has been looked at, and they summarised that in adults over 18 years old, there was an estimated 450,000 GP appointments 18,000 hospitalizations, and over 8,000 deaths attributable to RSV annually. Of these, 36% of GP episodes, 79% of hospitalizations, and 93% of deaths were in the over 65-year age group. RSV is known to cause outbreak in hospitals, and this is a case study from a French hospital where the mean age of patients were 89 years old and all of them had comorbidities. Genotyping confirmed this case as an outbreak, and despite infection control measures, it spread through this vulnerable cohort. Unfortunately, 2 patients passed away. The economic burden has been summarised recently in a paper from August 24 in the US, and they estimated that for adults aged 60 and over, there was an economic burden of 6.6 billion, and that included both direct and indirect costs. The 4% of hospitalised cases accounted for 94% of all direct costs. Looking at outcomes by age, there's an estimated RSV-associated community-acquired pneumonia case of 0.8 per 10,000 in the 50 to 64-year age group, going up to 5 per 10,000 in the over 80s. One study from California looked at those over the age of 60 admitted to hospital with RSV and found that survival after 1 year post-hospital admission was 84% in the 60 to 74-year age group, dropping to 68% in the 75 and older age group. Looking at long-term outcomes again for RSV, this graph is a 1-year survival comparing RSV to influenza amongst a hospitalised cohort. RSV admissions were on average slightly older, with a median age of 77.5 versus 77.4. Chronic heart failure, COPD and asthma were more common in this cohort, but as the graph shows, at 1 year the survival rate for influenza-related admissions stands at 81.2%, whereas it was 74.2% for RSV.